Hi, I'm Dr. Alicia Duyvejonck. I am a nurse practitioner and a headache specialist at Genesis Neurology in Davenport, Iowa. I have been working in general neurology since 2014 and became certified in headache medicine through the National Headache Foundation in 2018. I'm currently working on developing my area's first multidisciplinary headache clinic, I'm super passionate about headache and migraine patients. I'm also extremely passionate about teaching, and I'm really happy to be able to share my knowledge of headache and migraine with you today. So today we're going to do a Migraine 101 talk. And really, when I put this talk together, it was hard to kind of pare down all the different topics. So this lecture really became a what the headache specialist wants you to know. So a lot of this information I'm going to give is a lot of information that related to problems maybe that I see coming into my clinic and things like that. So hopefully you find it helpful. Of course, these are my faculty disclosures. I do work with a variety of pharmaceutical companies on migraine-specific therapies, usually as a speaker or through advisory boards. So why are we here today? Why is migraine important? Well, it's an extremely prevalent and disabling disease. So over 31 million Americans live with migraine, and that turns out to be about 1 out of every 4 households in the United States that have a person with migraine living in that household. It's been identified by the World Health Organization in their burden of disease study in 2016 as the second most common cause of years lived with disability in the entire world. And I think that surprised some people. But really, if you think about it, these are people who are losing hours and days in really what's supposed to be their most productive years, those teen to early to mid-adult years. This interferes with work productivity, educational goals, relationships. It contributes to absenteeism and presenteeism, which means you're actually at work, but maybe your mind isn't totally working 100% in your work. And roughly half of those with migraine receive an accurate diagnosis. I think that also surprises people, right? How is it hard to diagnose migraine? Well, sometimes migraine can be tricky, and the diagnostic criteria aren't always straightforward. It's one of those criteria where, well, you have 2 of these factors and 1 of these factors, or you can have this factor. So it can be a little bit tough, especially for those who are not headache providers. You're out there working in primary care, urgent care, ER, these kinds of places. So you are seeing a wide variety of patients and you don't have a lot of time with each patient. So I'm hoping to really help you through that diagnostic process today. So many times the first question that comes up in a migraine consult is, why do I have migraines? We have to figure out why I have this horrible condition. And really, it's one of the most easy questions to answer. The answer is it's a genetic condition like so many other conditions. There's actually 40 genes that have so far been identified that encode for various primary headache syndromes. And every person has also a unique genetic threshold. So I call this kind of this imaginary line that if given the right circumstances, with enough contributing factors or contributing events, that person will kind of go over that line and thus express their specific headache threshold or a specific headache phenotype. So a little bit about migraine pathophysiology. We have really come a long way in the past couple of decades, really figuring out what migraine is. I think most of us that have been practicing for any amount of time really remember those older days where we had kind of that vascular theory, right? We knew that in migraine, we had these dilated, swollen, angry vessels. And we thought, well, vessels are pain-sensitive structures in the head, so maybe that's why we see migraine. And then we take a medication like triptans that have been around for a long time that we know are effective for treating migraine. And we know that those medications, one of the things that happens with those medications is vasoconstriction. So that kind of went along with that vascular theory. But actually, with further research, we found that the vessel dilation is actually a result of the migraine signaling that's going around in the central nervous system. So the sensory fibers that are involved in migraine arise from the trigeminal ganglion and the trigeminal nucleus caudalis in the trigeminal-vascular system. And you can see that on the figure on the right, all of these little lines. I know it's a little confusing, but really this sits around that, right in that brain stem. And these nerve areas are activated by mechanical, thermal, or chemical stimuli. And this is, so the brain sensitive structures of the brain is actually not the brain tissue. It's the meninges, it's the vessels, it's the musculature around the head, neck, and shoulders. And when these nerves in these areas are activated by this stimuli, then we start expressing all of what I call this inflammatory soup. And this has a variety of chemicals in it, but you, of course, recognize serotonin, histamine, bradykinin, some others that really then lead to the release of the neuropeptides like CGRP, which of course has been kind of the hot topic in migraine over the past several years. And that's what really causes that release of the neuropeptides, and that thus sensitizes meningeal pain receptors and allows the migrainous signal to progress. I will point out here, these centers in the trigeminal vascular system, these are actually adjacent to, but not within the brain. So these are actually peripheral nerve areas, even though they're very close in the brain. And that actually makes a difference when you're looking at certain medications. Do they work in those peripheral nerve centers? Or do they penetrate the brain and work more centrally? So you may choose different products because of that. Although I'm not getting quite into that depth in today's talk. So I said that CGRP, or calcitonin gene-related peptide, has really been the hot topic over the past several years. Really, it's been the focus of migraine research for the last 20 years, but it's really taken us that long to translate that into safe and effective therapies. But we know that CGRP plays a key role in migraine pathophysiology through arterial vasodilation, neurogenic inflammation, and activation of those meningeal nociceptors. We reviewed all of that on the previous slide. This also enhances synaptic transmission through glutamatergic signaling, and it contributes to peripheral and central sensitization. So we talk about central sensitization in migraine, and really what that means is the migrainous signal has moved from those peripheral nerve areas around the brain and have really progressed up into the central portions of the brain. And I kind of consider this a point of no return, so to speak. This is why when you use triptans or older anti-migraine medications acutely, that we really pound into our patients, you have to take this medication as early as possible. And it's because those medications act in those peripheral nerve areas. And if you allow the migraine to progress into the point of central sensitization, where the migraine signaling has gotten into the central portions of the brain, those medications are not going to work as well. And really, we say those patients probably have a 30 to 60-minute window to treat that migraine to really get optimal effects before you start hitting some central sensitization. So that's really important to know. But these CGRP targeted therapies have really completely changed the landscape of migraine treatment since the initial FDA approval of the first CGRP monoclonal antibody, and that happened in 2018. But even when you look at some of the older migraine treatments, whether they're preventative treatments or acute treatments, a lot of those treatments actually affected CGRP levels indirectly because they were blocking other chemicals that led to the CGRP release. For example, on the previous slide, you saw that part of that inflammatory soup was serotonin. So we know that we have a lot of medications, including triptans and certain antidepressants, that affect serotonin levels. So we know older antidepressants, the tricyclic antidepressants, some of the SNRIs, things like that, actually affected serotonin, which then indirectly decreased CGRP levels. So I think here it is really important to talk about the phases of migraine. I would guess that many of you watching this lecture didn't know that migraine had 4 phases. And I will say there's actually 5. There's an interictal phase that we'll talk about on some of the next slides. And that's the time in between migraine. But then when you're looking at migraine, I think we're all really good at identifying this red area, right? That's the headache area. It's often a throbbing type headache lasting 4 to 72 hours, associated with sensitivities, nausea, things like that. I think that's an obvious thing. That's what patients are coming to complain to us about. Some patients have aura. It's actually only about a third of patients actually have a migraine aura prior to the onset of the headache phase. But a lot of people are aware of that. And I think most providers are aware of aura. But I think what we miss is the bookends. We miss the prodrome and the postdrome. So prodrome is hours to days prior to aura or headache, where patients have a variety of non-painful symptoms. This can include difficulty with concentration, irritability, difficult with finding words, insomnia, yawning, nausea, fatigue, some of the sensitivities, increased urination or food cravings. There's actually a theory out there, we always blame chocolate, for example, as a headache. We always blame that as being a migraine trigger. But there's a thought out there now that is chocolate truly a big migraine trigger, or do patients in their prodrome crave chocolate and then get the headache and then end up blaming that headache on the chocolate? So it's kind of what came first, the chicken or the egg kind of situation. The postdrome on the back end, after that headache has resolved, is what I call my migraine hangover. I feel like I've been hit by a Mack truck. I can't concentrate. I'm irritable. I'm depressed. I'm fatigued. I have trouble understanding things. I'm just not really at 100% mentally. And some people can even feel some euphoria type symptoms during this stage. But I think that the importance, there's a couple of really important things when we look and when we learn about these phases of migraine. First of all, if you're the first provider who talks to a patient about prodrome and postdrome and explains this process, they're going to be so impressed with you because you just explained their entire life, right? That's a really common question in my clinic. Why, when I'm not having a migraine, am I still so nauseous? Why am I so light sensitive? Why do I always feel like this when I don't always have a headache? So that, first of all, is helpful. It explains to a patient maybe why they're having some symptoms. I think it's also helpful as a provider, because if you think, and I even reference myself, maybe early in my career, twice a week migraine, not too bad, right? I kind of grew up, so to speak, in a general neurology clinic. We've got a lot of chronic migraine here. And so it wasn't unusual to have a patient be quite happy with twice a week migraine. But if you really look at this chart and you think, okay, my patient has migraine twice a week. So you have prodrome for hours to days. Maybe you have a migraine. You have a headache, hours to days. And then you have postdrome, hours to days. Put that all together and say, okay, you're having that twice a week. And I want you to do that calculation. That's constant migraine signal, right? So your patient who you think isn't doing too bad because their migraines are only twice a week, they only have 8 migraine days per month, that patient may not be doing so well. They still may be in constant migraine cycle, depending on their situation. So I think that's really important to take into consideration when you're looking at how to treat a patient and when to start thinking about migraine prevention. The interictal phase, I told you before, is kind of that time between migraine. The functional MRI studies that have come out actually show that there is altered brain function in migraine patients, even between attacks. So these patients, you see these patients, right? They're wearing sunglasses all the time, or you have your high schooler that comes and says, I'm fine until I get into this class. And the lights are just terrible, and I'm by the window and the sun is shining in, and there are loud, noisy kids in my class, and it always triggers my attacks. These patients are hypersensitive to stimuli. In fact, there's also been a newer theory that migraine is on the spectrum of sensory processing disorders, not dissimilar to things like autism. And interestingly enough, patients with autism have higher rates of migraine than the general population. So that's very interesting as well. So it's not uncommon for patients to report, GI symptoms, dizziness, migrainous sensitivities, cognitive dysfunction, these kinds of things, even in between migraine attacks. In addition, the interictal phase is really important to talk to patients about because there's so much anxiety, anticipatory anxiety involved in the interictal phase. So that patient who has debilitating migraines has to think, even when they don't have a migraine, well, can I plan this event? Can I plan this vacation? Can I plan my wedding? Can I take this new job? Because they're thinking about, but what if I have a migraine that day, right? That's anticipatory guidance in the interictal phase. And that can, of course, lead to more disease burden as well. So here are the migraine diagnostic criteria. It's actually, just for space sake, I simplified it a little bit, but you can see, you get the diagnosis after 5 attacks. It lasts this long. You have 2 of these symptoms or qualities, at least one of these symptoms, and it's and these kinds of things. So a little bit complicated. I don't want you to memorize this. So stop taking notes. These are the classic criteria. Now, why would I not want you to memorize this? Well, the fact of the matter is, I've already told you that we're only diagnosing migraine correctly about 50% of the time. And you don't have time for this. You're a non-headache provider. You're in the ED, the urgent care, the primary care, women's health areas. You have to get these patients in and out. So you just don't have time for this. So I'm going to help you. We're going to talk through a couple of different tips on diagnosis. And I apologize, I have just a couple of slides that are out of order that I forgot to fix before this lecture. So I'm just going to touch on Migraine Aura before I move on to those diagnostic pearls. So Migraine Aura is fully reversible aura symptoms. These can involve vision, speech, language, sensory, motor, brainstem, or retinal symptoms. So a wide variety of possibilities, and they should have at least 2 of the following characteristics. At least one aura symptom spreads gradually over 5 minutes or more, or 2 symptoms occurring in succession. Each aura symptom lasts 5 to 60 minutes, and at least one symptom is unilateral. Now, some of the symptoms, of course, are non-lateralizing. You can't lateralize dizziness, so that does not count. It counts as an aura symptom, but that does not have to be unilateral. Aura is accompanied by or followed by headache, and there is a possible lag phase that lasts up to 60 minutes. So back to migraine diagnostics. So only about 1/3 of patients have migraine aura. So make sure that you are not ruling out a migraine diagnosis simply because the patient isn't reporting aura, because the fact of the matter is, more often than not, they don't have aura. The diagnostic criteria, these were made by the International Headache Society. They do not require GI symptoms. So you cannot say the patient doesn't have migraine because they're not nauseous or vomiting. That is not consistent with the diagnostic criteria. Vomiting actually occurs in less than 1/3 of migraine patients. And remember back, I didn't read out all of the criteria, but in that criteria, kind of your classic migraine is a unilateral throbbing headache, right? Well, but 41% of migraine patients have bilateral pain. Well, gosh, no wonder we get it wrong if we're sitting here telling people to look out for a unilateral headache and 41% of the patients have bilateral pain. 50% of the time, migraine pain is non-pulsating. So it doesn't have to be unilateral. It doesn't have to be throbbing or pulsating, even though those are a part of the diagnostic criteria. How confusing is that? It has to do with that if this, then that, one of these 2 and one of these 4 kind of situations. They're complicated guidelines. So hopefully this is helpful for you. ID migraine is one of my very favorite things that have come out. This came out in I think a couple of years ago with some research that was done by Dr. Lipton and some of his partners. And this is it's a validated tool. And this is a really good, quick and dirty way to screen your patients for migraine. So if your patient's coming into the clinic for a migraine complaint, or maybe you're seeing a patient for their yearly exam and you're just screening, hey, you're a middle-aged woman, do you have any headaches kind of inquiry, which I, of course, encourage you to do. You can use this 3-item migraine screener, and even your staff can do it, or you can even make a little piece of paper and the patient can fill it out themselves in the room while they're waiting for you. So ask the patient, do you feel sick or sick to your stomach or nauseated with your headache? Does light bother you with your headache? And does your headache limit you from doing what you need to do for any day in the previous 3 months? If your patient says yes to one of these, you should at least ask additional questions and consider a migraine diagnosis. If patients say yes to 2 of these things, your probability of having a migraine diagnosis goes way up. If the patient has all 3, I mean, that's almost, I think in the study, I think that was like 99% accurate in identifying migraine. So these 3 questions can really help you immensely and lead you to a possible migraine diagnosis and help you create a more effective and appropriate management plan for your patient. When I first started in headache, I was lucky enough to work with a physician named Brad Torfey. He was formerly of the Diamond Headache Clinic. He now is the medical director of the Chicago Headache Institute and Research Center. And he really took me under his wing at the beginning of my career when I was learning about migraine. And I'll never forget this quote that he told me, which I actually have since heard that is actually a Seymour Diamond quote. Actually, he said this first, but it was Dr. Torfey who taught me, any patient presenting to your clinic with a complete complaint of headache that interferes with their daily activities. I've had to miss work. I've had to stay home from school. I missed a family event, or I can't participate in my sports. That should be assumed to be migraine until you have proven otherwise with the diagnostic criteria or some other diagnostic testing that indicates a secondary cause. So hopefully those pearls are very helpful to you. The other thing that I want you to think about when you're trying to diagnose a patient with headache is the fact that there's really no such thing as a sinus headache as an ongoing cause of frequent headaches. Rhinosinusitis as a primary cause of headache is rare. If you do have a sinusitis, that can be a contributor for headache and some migrainous symptoms, but it's not usually the primary cause. Usually if somebody is coming with significant sinus headache issues, you really want to consider a migraine diagnosis and obtain additional history. What are their sinus headache symptoms? Is it simply I have a headache and I feel it in my face and I feel congested? That doesn't necessarily equate to a sinusitis diagnosis. Especially if you have that patient who says, oh, I get sinus headaches twice a year, never fails. I have to be on a Z, it's one of these patients, you're ordering Z-Paks or whatever antibiotic that you use for them twice a year, 4 times a year for their sinus headaches. It's just a regularly occurring thing, or gosh, they do a course, you have somebody who has this situation, you order them a course of antibiotics, they're not getting better, or they kind of get a little improvement and then they get worse again. I really challenge you to consider a migraine diagnosis. Ask about family history. Ask about other symptoms like migrainous sensitivities, nausea, vomiting, dizziness. Are they running a fever? You would expect if someone had a significant sinusitis that would contribute that badly, they might be running a fever. Maybe they might have a elevated white blood cell count. Or maybe if you have this situation with recurrent sinus infection, grab a sinus CT or send them to ENT. Make sure that there's actually a sinus issue that you're addressing. I see so often where patients and their well-meaning providers have really been chasing sinus infections several times a year for decades. That's not sinus headache, that's migraine. And you really should consider adding a migraine specific treatment option. You know, I have lots of patients who swear they have sinus headaches. And I don't just sit and say, well, you're wrong, you need to listen to me. But I do some shared decision making. I say, you know, it sounds like your sinus headaches aren't being adequately treated with these antibiotics or not adequately treated with the Sudafed, not completely 100% better. What if we add a migraine specific option to that treatment the next time you have an episode? So maybe I won't just give you Sudafed or that Z-Pak. Maybe I'll give you a migraine specific acute medication to try. And I've done that with several patients. And it's amazing how often they come back and they say, you know, that worked way better than my sinus medication because it wasn't sinus headache in the beginning. Withholding migraine treatment. Thankfully, I don't see this as often as I used to, but I do still see patients where they say, you know, my primary doctor didn't really start me on anything. They just said, I'm depressed and kept trying to give me antidepressants. Or, my doctor says, you know, I'm very overweight and that's contributing. So they really want me to lose a certain amount of weight before they start treating me for this kind of condition. But really the fact of the matter is that there's lots of contributing factors to migraine, but the patient has to have the right genetic makeup to have this condition. It's really, in my mind, not ethical to withhold treatment because you think that there's some other disease process going on, unless of course you feel like, you know, there's some safety issues, certainly. But the preferred approach really, even if you're suspicious that there's a secondary headache process or you think there's a significant contributing factor, really the preferred approach is to treat the migraine and give migraine specific treatments, whether that's acute, preventative, or both, while performing a diagnostic workup or treating the other contributing factors, right? Give them some acute migraine medication while you address their mood issues. Get them into physical therapy to treat their neck and their TMD, just all of these other things. So make sure that you are giving them some medication for symptomatic control while you're investigating other possibilities. So I said there's lots of contributing factors for migraine, right? Anything from stress to sleep to diet, mood issues, environmental sensitivities, hormonal changes, metabolic changes, physical or psychiatric illness, certain medications, and of course musculoskeletal issues. I never knew how rampant temporomandibular disorder was until I started in headache medicine. Of course, my view is skewed because I see mostly headache patients, but you know, look at their jaws. Feel their jaws. Are they tender? Are they popping? Are they clicking? Get them into a good physical therapist to address their cervical and TMJ issues. Very, very important. I talk about migraine hygiene a lot with patients. I tell patients kind of the easiest way I've been able to explain what migraine is to patients is by telling them that this is a genetic hypersensitivity of the brain and the nervous system. And what migraine brains are sensitive to is change. So we want to create as stable of an internal and an external environment as possible when we're talking about migraine. So patients need to follow a consistent sleep schedule. They need to get 6 to 8 hours of sleep a night. They need to hydrate. I know almost nobody hydrates enough, 60 to 100 ounces of water daily. It is not unusual. This needs to be non-caffeinated. I don't care that your coffee and tea are made with water. I don't care that your beer is made with water. Those don't count because you're peeing them out because of the alcohol and the caffeine. Non-caffeinated water flavorings or electrolyte drinks are okay. But it is so common in my clinic to sit down with a new consult and find out that they're drinking 2 16-ounce water bottles a day, and they think that they're doing well with their hydration. So make sure to address that. Patients need to stabilize their blood sugars by eating a snack or meal of nutritional value every 3 to 4 hours while they're awake. When they go longer than that, Of course, their body's spilling sugar into their blood to make up for it. They're running through it. So really what it creates is this just bouncing up and down of the blood sugars. Even if that is within the normal blood sugar range, the migraine brain is just not happy when it has all of this fluctuation. So you really want to even that out with frequent meals and snacks. Regular exercise, very helpful for migraine. There's actually studies that show that implementing a regular exercise regimen and maintaining a normal BMI or losing weight is just as effective as certain preventative medications. So certainly helping patients to incorporate that into their lives can be very helpful. And of course, you want to take in their personal abilities, resources, limitations, start slowly to avoid injury, these kinds of things, like you would with any other patient. Patients should limit their caffeine intake to no more than 400 a day. And I really like them below 200, to be honest. So 200 to 400 milligrams daily of caffeine. And it shouldn't fluctuate significantly day to day. If they are using caffeine excessively, I do come up with a plan with them to reduce that gradually. You don't want to stop caffeine or reduce suddenly. Of course, that's going to induce a lot of migraines and headaches. But having kind of a plan for, weekly decreases in caffeine while you're increasing water can be very helpful. Also, we want to manage stress and psychiatric conditions and really consider utilizing relaxation exercises, meditation, and yoga. Cognitive behavioral therapy can be quite good. And a lot of these interventions have great efficacy in the research. So really consider doing those things for your patients as well. Migraine diet. Again, this is something you're never going to have a patient follow this diet strictly. It's extremely difficult and restrictive. I find that it actually causes more anxiety than and perseveration than anything. But I just think it's good information. So this is kind of the quote migraine elimination diet. Basically, you take all of these things out for 12 weeks and then reintroduce them one at a time, no more frequently than once a week. Super difficult. I will tell you, almost nobody does this, but I think it's helpful for patients to know. Fresh is better. MSG is in almost all processed foods, so shop around the perimeter, right, where your fresh foods are. We talked about avoiding caffeine, avoiding wine and beer, especially to excess. You want to decrease sugar intake, but also avoid artificial sweeteners because those can be migraine triggers. Soda, again, very sugary. Soy, aged cheeses, soft cheeses actually are better. So they can certainly do, that's supposed to be cream cheese, not cream. Cream. And that's supposed to be cream cheese and cottage cheese. I don't know how that happened, but I will fix that for my next lecture. Singles and Velveeta, interestingly enough, even though they are processed, they're better than the aged cheeses. A real good rule of thumb is if you can slice it or shred it, it could be a migraine trigger. Processed meats, remember lunch meats, anything cured, aged, smoked, anything like that is all highly processed. Hot dogs, ham, salami, pepperoni. I just ruined everyone's pizza, I know. Beef can be tricky. Interestingly, kosher beef is okay. Buffalo and lamb are okay. You want to decrease and avoid yeast as much as possible. Basically, if your bread's not flat, it has yeast in it. So make sure you want to at least limit your intake of those things and avoidance of certain nuts or nut butters. Migraine-friendly foods, things with magnesium are really good for patients. So, having a water flavoring or an electrolyte drink that has magnesium in it can be helpful. Green leafy vegetables, avocados, cashews have a lot of, even though they're nuts, they have a lot of magnesium in them. So those can be helpful. Those would be very usually migraine friendly foods. So moving on to some of our treatment of migraine. First, I am going to go through some of the medications we use for migraine, but I'm not really going to focus on specific products. That's really not my focus today, but I'd really like to talk about strategies for acute migraine treatment. So we've got three basic strategies when we look at acute treatment. Step care cross attacks. This is very common. This means you prescribe a medication, the patient uses it for several attacks. They come back to you, you say, hey doc, my treatment's not working, so we switch them to something else, and they try that for a while. That's step care across attacks. Step care within attacks. This means that we're starting with product A and we're escalating therapy for the same attack if the initial treatment is not effective. So this might be your patient that says, oh, I start with some over-the-counter naproxen, and then if that doesn't work, then I take my triptan, and then if that doesn't work, then I take my other treatment. I take my Gpant, or I take, hopefully not your narcotic, but they are out there. So that is step care within attacks. That can be helpful, but I want you to think back to what we talked about in the beginning about the stages of, or not the stages of migraine, but the pathophysiology of migraine, right? It starts in the periphery, and then over about an hour or so, it spreads into the central areas, causing central sensitization. We need to catch the attack. So that's the problem with the step care within attacks, is that if you do that, you may end up missing your window of opportunity to really treat that migraine most effectively. Stratified care actually is the biggest recommendation from the American Headache Society for especially difficult to treat attacks, or difficult, maybe more of those chronic intractable migraine patients. So this would be utilizing different medication options for first-line treatment based on specific headache characteristics or environmental factors. So I may have product A that I will use when I'm at work. If a migraine develops slowly over an hour or two, I can take option A. I have a different kind of migraine, maybe where I wake up and I am in a full-blown migraine. I missed the beginning of the migraine because I was asleep. It is full-blown, it is at a 10 out of 10, and I am not going anywhere. Or maybe it's an attack that developed very quickly during your day, right? This escalated within like 15 minutes. I went from a 0 to a 7, and it just escalated very quickly. And now, you know, maybe that other first-line medication that is really effective when I can catch my migraine, that one's not going to work. So I have product B for that kind of a headache. And maybe I have product C as my rescue. When all else fails and I am about to get my butt to the ER, then I'm going to try my rescue medication before doing so. But that's really the best option for someone who has difficult to control migraines. Of course, these are the general groups of medications that we use for acute migraine treatment. Most patients are going to be trying over-the-counter medications, analgesics and NSAIDs, naproxen, ibuprofen, acetaminophen, some of the combination treatments, aspirin, they're all over the counter. There are some other options that are prescription, whether that's oral or in an intramuscular injection or IV. Triptans, these have been the standard of care in acute migraine treatment since the 1990s. We have a variety of options. We've got a variety of routes. It's really nice to have some of these injectable or nasal spray routes for your acute migraine treatment because that bypasses the stomach. Patients do get gastroparesis during migraine. That's why patients sometimes feel nauseous or vomit because their stomach just stops moving. So in those patients, sometimes oral options are not the most effective because they're not getting through. So a nasal spray or injectable option can be much more effective. Ergots or ergot derivatives can be very helpful. These are actually some of the oldest medications we use, but I still use them fairly regularly in my clinic. We can do subcutaneous or IV DHE. We've got Migranol nasal spray. We've got Cafragot, which is an ergotamine combination medication. The one that's not on here, because I made this before it was FDA approved, is one called Trudesa. That is a DHE nasal spray in a more effective delivery device. It's got like gas propelled or something. So it gets it up into the upper nasal cavity where it needs to go. So that's kind of a new toy we've got. Dopaminergic medications, metoclopramide, prochlorperazine, chlorpromazine. These medications, really, if you look them up, they're antipsychotic medications, but most commonly people use them for nausea. But there's actually good evidence in the research that these medications actually help to decrease migraine signaling and can be really helpful in combination with other acute migraine treatments. So those can be very helpful. We've got gepants that have come out onto the market over the past couple of years, Nurtec and Ubrelvy being the two options. And then, of course, we've got Rayvow, and that is a Ditan. It's the only one in that class. It's also a serotonergic medication like the triptans are, but they have completely different functions, those serotonin receptors. So a couple of other things to think about. Cardiovascular risk is really important thing to keep in mind when you're using triptans or ergots. You don't want to give anyone with significant cardiovascular risk those medications because they do constrict vessels. So if someone has history of hypertension, hyperlipidemia, diabetes, they've had strokes, heart attacks, maybe certain people with blood clots, I really will use a non-triptan or non-ergot option. Rayvow has it penetrates the brain more than some of the other products, so it can be really effective. But when we penetrate the brain with medications, it does cause some side effects. So there's some sleepy, dizzy side effects that go along with using Rayvow that your patient needs to be aware of. So that isn't going to be the option to use for every single attack, right? Because if a patient is needing to drive or is at work, they need something that won't cause side effects. Gepants can be really nice, good side effect profile, really low rates of side effect, and these don't cause medication overuse or rebound headaches. They have some of their own limitations as far as medication interactions. So there's goods and bads about every option, and really I'm just very excited in this day and age where we have all of these options so that we can really tailor our treatment to each individual patient. I may talk about it in a coming slide. I don't remember, to be honest, but also in here would be neuromodulation devices. There's several of those out on the market. They've got great efficacy and really superior safety in so many ways. You know, it's not a systemic medication. It doesn't have a lot of side effects. The downfall on those is cost. They're not well covered by insurance. But can be a great option, again, just in the toolbox, right? Narcotics and barbiturates. Narcotics and barbiturates had been widely used for migraine treatment in the past. Butalbital is kind of the most common barbiturate that's been used in migraine, but they're associated with significantly higher rates of rebound or medication overuse headache. So these ultimately cause way more problems with your patient's headache over time than I believe that they're worth. They're also associated with dependency, addiction, withdrawal, and there's a risk of overdose. So they're risky medications. They may make your patients worse. And really, with all of the great options that that have been developed over the past several years, I feel like I don't really need to go there. So actually, my headache clinic is narcotic and barbiturate free. There are some clinics out there that will do it. You'll see a lot of maybe your older patients that have had migraine for quite a long time. They've just been on these medications chronically. But I'm really happy to report that with some of the newer products that I reviewed on the last slide and some of the products that we're going to go through for prevention on some coming slides, I've actually been successful in getting patients off of chronic narcotic and barbiturate use. We can do this. We can get patients off of these medications. And that's been really exciting in my clinic. So migraine prevention, when do we think about migraine prevention? So the American Headache Society came out with guidelines that said you should consider migraine preventative treatment if your patient has 4 or more migraines per month, or if they have 2 or more migraines per month and it's associated with moderate to severe migraine associated disability. If your patient is missing work regularly, but they only have 2 migraine days per month, they might be eligible for prevention. For example, I have one gentleman that I always talk about when I talk about these guidelines. He has 1 or 2 migraine days per month. I think maybe 2 most of the time. So that doesn't sound too bad. But he has a very prominent migraine aura that lasts throughout his entire migraine. So it lasts several hours where he cannot see at all. The man is a truck driver. And I don't know anyone who has an employer that's okay with you randomly and suddenly missing work twice a week consistently every month. So that person should probably be offered a migraine preventative. And of course, that particular patient is now on migraine prevention and doing quite well. These 6 boxes, these are your 6 general boxes where you're going to pull your migraine prevention from. So the first 2 on the top and the red box in the middle, these are your old generic oral preventative medications. We've got certain antidepressants, certain antihypertensives, and certain anticonvulsants. We found over the years that a lot of these just happen to also work for migraine, right? And it kind of makes sense when you think of some of the pathophysiology, right? We said that inflammatory soup is serotonergic. We know that anticonvulsants kind of calm down nerves in the brain and make them less excitable. We know that antihypertensives and beta blockers, they dilate blood vessels and they can calm things down in that kind of a way. So we've used these for decades. A lot of them, they're quite good medications for the right patients. And I have lots of patients that never need anything more than this. But when or if you have patients that do, we now have a variety of other options. I'm actually going to jump down. I'm going to start with Botox because that's the one in the pink box that's been around for the longest. This came out in the 90s, the 1990s. We found that all of the middle-aged housewives that were coming in, getting their wrinkles taken care of, said, hey, by the way, my migraines seem better. They started some trials and found out, yep, this is an effective migraine treatment. So we inject, you have to be a trained injector. You inject Botox into 31 different sites. These are superficial intramuscular injections around the head, neck, and shoulders. In those areas are those that have very prominent nerve areas that are involved in migraine. So those nerves absorb the Botox and it changes the way those nerves communicate. It changes that inflammatory soup and the resulting neuropeptides that are released. More recently, we have come out with Cprp monoclonal antibodies. The first one came out in 2018. And now we have 4 different products. Aimovig, Emgality, and Ajovy are once monthly or once every 3-month options. They are injections at home using an easy-to-use auto-injector. Those have been very helpful for patients. And we now also have Vyepti, which is an IV option that's infused every 3 months. The monoclonal antibodies are great. They have minimal side effects. They're large proteins, so they don't get excreted through the liver or kidneys, so there's no drug-to-drug interactions. Injection site reaction really is the most common side effect of the at-home injectables. And nasopharyngitis, of all things, is the most common Vyepti side effect. So really quite well tolerated. When you're talking about Botox and monoclonal antibodies, it is important to tell your patients that we need to get through at least a 6-month trial. Based on the studies of all of these medications and treatments, really indicate that it takes time to build up to full effect. If a patient gives up on these 2 to 3 months in, they might really be missing out on some great effectiveness. I've actually had a few patients who really gave it the old college try and stayed with it for a year. And that was the magic amount of time for them to really see that good efficacy. So I'll bring them back sooner and we'll work on other things like contributing factors and acute treatment and those kinds of things. But really, I make sure patients understand we need to give this a good 6-month trial before we give up. I didn't mention Botox side effects. Again, injection site reaction, redness, swelling, pain, where you get the shot. A few times a year, I come up with somebody with an eyebrow issue, either a ptosis or what I call spocking of the eyebrow, where the eyebrow is raised. The nice thing about those side effects is it wears off, right? But you have to do Botox every 3 months because it wears off. So these side effects last maybe a month or two most of the time. And when you hear about more concerning side effects of Botox, distance spread effect, difficulty swallowing, difficulty breathing, this is a label on all Botox products because it's a class effect. And usually we see that when we use Botox for other conditions, usually high doses and near airways. Migraine protocol uses low doses and does not go around airways, and there have not been any documented cases of distance spread effect in migraine protocol using Botox. So I just like to tell people that so you can share that with your patients. G-pants for prevention of episodic migraine are our most recent development, Nurtec and Qulipta. Nurtec's every other day, Qulipta's every day. So these have a few more side effects than their monoclonal counterparts. Nausea, tiredness, constipation are possible. And there are some drug-to-drug interactions, just like there are when you use G-pants for acute migraine treatment. So these are mostly medications that utilize the CYP3A4 hepatic pathways. So just make sure you're using your interaction checkers. A lot of times it's more of an efficacy issue than a safety issue, but we do want to be mindful of any interactions that might come up. So non-pharmacological therapies, there are lots of other things that we can do. I take much pride in the fact that when I have patients that come to me that have a value for more holistic or non-pharmacological therapies, I can help them. I can still help them to get their migraines under good control. And I do this by not only lifestyle change and addressing contributing factors, but I use, there's really great evidence in the research for physical therapy, neuromodulation or neurostimulation that I referenced before. We have actually devices both for acute treatment and preventative treatment now. Some of the devices can do both with one device. Acupuncture, tons of evidence for the benefits of acupuncture and biofeedback. In migraine, I actually have a neurofeedback provider in my area that I utilize, and I find that very helpful, specifically in some of my head injury or functional neurological disease patients. Chiropractic or osteopathic manipulation can be considered, massage therapy. Cognitive behavioral therapy or pain psychology can be very helpful. And I will tell you in the pediatric population, there is huge benefit to CBT. It's good for adults too, and I do recommend it. But really the optimal time to catch these patients is when they're children and teenagers, because they just respond so beautifully to cognitive behavioral therapy. And then of course, we're going to be talking a lot about lifestyle modification. And those are all of the things that I talked about more towards the beginning of the program. There are actually good nutraceutical and herbal therapies for migraine. Patients ask this question all the time. Isn't there something I can start with that's natural? Well, the answer is yes. We've actually have a lot of good research that shows magnesium, riboflavin or B2, CoQ10 and methylated folate can all be helpful. Magnesium and CoQ10 can cause some GI symptoms. Folate's fairly benign. I've had a couple of patients that say they think they get a little constipated. Riboflavin, interesting, it turns your urine bright yellow, but really has minimal side effects otherwise. I tell people the riboflavin, you really have to do a supra-therapeutic dose. You won't find it over the counter. It's a 400 milligram riboflavin dose, but you can find that at any health food store or Amazon. I had a patient tell me recently if they talk to their pharmacist, the pharmacist can actually just order it in for them if they're interested in trying that. Butterbur and feverfew are herbal therapies that do have good evidence for migraine. The only thing is you'll have a lot of patients who kind of do these two on their own or come in and say, oh yeah, I tried that, or maybe I'm on that. The thing to really remember with these is that they can cause some liver problems, fairly similarly to some of the medication that we use. It doesn't mean I don't use them, but I do monitor their labs, and I'm cautious when I add more pharmaceutical options that can affect the liver. I'm a little more cautious, and maybe if we're needing to progress and these other things aren't helping, I might say, you know what, can we take a break on these while we try to maybe find something that's more effective? I'd like to talk about menstrual migraine a little bit. I find this is one of the most common things that I see. And even today, actually, I had a patient that came in. She talked about having menstrual migraine, and her provider was she was asking about hormonal treatment, right? Can I take, is there a birth control pill I can take or something like that? And what she told me the provider told her was, you know, I really don't want to do that because so often when we put patients on birth control, their migraines get worse. Well, I told her, I said, well, I would assume that just means that particular provider just wasn't I don't want to say they weren't knowledgeable. They're very knowledgeable, but they just didn't know how to manage the hormonal medications within the context of migraine and how to improve patients instead of worsen patients. So I like to kind of talk through this. So migraine occurs menstrually in women because of a rapid drop in estrogen. So this happens in the late luteal phase and the early follicular phase. And then that early follicular phase, also you have that drop in progesterone as well. So usually you can have some increase in migraine here and there around ovulation. That's harder to pick up on unless you're keeping really strict migraine diaries, although I do recommend those migraine diaries. But mostly when you hear patients talking about menstrual migraine, it's usually the 2 days before up to 3 days after her menstrual cycle that they're really getting these migraines. And what is causing the migraine is estrogen withdrawal. So estrogen withdrawal is inflammatory. So when we're using traditional birth control pills, you're usually looking at like 30 mics, right? 30 mics of estrogen. So if my estrogen level is here, and then I'm going to have my period, so it drops to here, right? That's inflammatory. Well, what if I'm taking a high estrogen birth control pill? What if I'm taking 30 mics of estrogen? Well, now my estrogen level's up here. Like this is my normal baseline. Now my estrogen's up here. So now instead of going from here to here, now I'm going from here down to here. So I have a much larger drop. That's why a lot of birth control options will actually worsen migraine because it's creating a bigger estrogen withdrawal. So that scares providers, and then they don't want to order birth control pills for any migraine patient. But I want to give you some tips for that. If we can stabilize hormones, we can help menstrual migraine. We can use the Depo-Provera, the IUDs, and birth control implants. Those things can be very helpful if they eliminate migraines. Sometimes that works for patients, sometimes it doesn't. If you're going to use an oral contraception, you want to do a couple of things. First, you want to choose the lowest estrogen content you can, 10, 15, or 20. I, of course, like the 10 the best because that's the lowest. You also want to consider some extended dosing. So maybe choosing a product that either doesn't have sugar pills at all and is just, you're just eliminating the sugar pills. There are some quarterly products that have sugar pills only every 3 months. So they're only dealing with menstrual migraine 4 times a year. There's also, I'm a big fan, probably one of my favorites is one called Low Estrin Fae. That's a 10 microgram estrogen birth control pill. It steps patients down in their estrogen dose over a few days, and then they're only on a sugar pill for 2 days and they start their next pack. So it really brings down their estrogen levels more gradually and more gently, and then minimal sugar days before they start back on their 10 mic estrogen. So this really helps to minimize menstrual-related migraines. If that's not enough, or if for some reason the patient doesn't want birth control, or birth control is contraindicated for whatever reason, I do mini prevention very often. In fact, probably my first step in managing menstrual migraines is using a long-acting NSAID. My drug of choice would be naproxen, because then you only have to dose it twice a day. But I'll take a naproxen, whether it's a couple of over the counter or maybe I'll give them a 500 milligram prescription, and I'll have them schedule that twice a day, every day during the time that they usually have their menstrual migraines. So that maybe that's day, -2 to day 3, right? Because that's when they have, it's usually only up to a 5-day course, but they'll just take that NSAID twice a day for that time. I do the same thing if that doesn't work or they can't take NSAIDs. I do the same thing with triptans or gepants. Triptans, naratriptan and frovatriptan are the best because they're the longer acting triptans. You can order, probably my most common is naratriptan 2.5 milligrams twice a day for 9 pills, right? Also, since the gepants have become available, I've utilized Ubrelvy once or twice a day during that time, or even a Nurtec once a day to every other day during the time where they'll have menstrual migraines. And that can be very helpful. I do want to talk about, because I gave this talk before and somebody asked about non-estrogen birth controls. Those can also be helpful. Again, they don't increase usually the menstrual migraines, but sometimes it's unless you're using extended dosing and not allowing a patient to have a period, sometimes it's just not good enough for the prevention of menstrual migraine. So yes, they're used. I have some patients who have left with them. So I just wanted to put that out there because it's not in these slides. A couple of other caveats for birth control. There have been previous reports of increased stroke risk in women using combined hormonal contraception. But remember that these studies were based on these studies were done in the 1960s and 70s when all we were using was high dose estrogen. Okay, we did not see, when they kind of redid studies with various estrogen doses, they did not see an increase in stroke risk with very low dose combined hormonal contraception with 20 to 25 mics of estrogen. And the continuous ultra low dose formulations, that 10 to 15 mic dosage, may even help to reduce aura frequency, which then actually could reduce stroke risk. So that's just kind of something to keep in mind. And like I said, extended dosing or estrogen step down options are very helpful in prevention of menstrual migraine. So I, of course, couldn't tell you everything. This is just a small snippet of just issues that come up in my clinic when I'm seeing headache referrals or consults. So I did want to give you some migraine educational resources. The Diamond Headache Clinic has a great research and educational foundation that you can see the website there. They have great, I think, free educational modules. The National Headache Foundation at headaches.org also has some good education modules. They also have great handout options that you can print out and give to your patients for education. And then the American Headache Society, just this last year actually, came out with their first contact program. So you can sign up for this. It's a virtual program that you watch on whenever it's convenient to you, or they do have some scheduled live events, I believe, as well. But this, you go to AmericanHeadacheSociety.org and look for that. It's a wonderful program for educating primary care and non-headache providers on how to manage migraine. It's such a prevalent disease, and there's not a lot of headache specialists. I, for example, am one of 3 in my state. We are not a state that has a lot of headache specialists. So it's really important to me and to the patients that non-headache providers really get as much education as they can in regards to headache, because it's just so important. And you guys really are the first line for these patients. And if we can educate providers like you and how to manage headaches and migraines, that opens up the headache specialists to take care of the more difficult, complex patients. So hopefully those resources are helpful to you. These are the references where I got the vast majority of the information that I presented today. And hopefully you found the lecture helpful. I do provide my email address. I'm always excited to talk to other providers, specifically other APPs, about headache. So feel free to shoot me a question or a hello. Just be patient with me and getting back to you. Thank you and have a great day.